Good afternoon and welcome to today's webinar, Increased Access to Medications for Opioid Use Disorder During the COVID-19 Epidemic and Beyond, brought to you by the Network for Public Health Law and the American Society of Law, Medicine, and Ethics. I'm Charles Strong, the Senior Digital Marketing Coordinator at the Network's National Office, and I'll be your host for today's webinar. We strongly encourage attendee participation and would love to hear from you, so feel free to submit your questions at any time during this webinar by using the Q&A tab on the right-hand side of your screen. All you need to do is click on that tab, select all panelists from the drop-down menu, and send us your question. We'll be addressing them during the Q&A session towards the end of today's event. Your moderator for today's webinar is Amy Lieber. Amy is a senior attorney with the Harm Reduction Legal Project. Before joining the project, Amy worked briefly in litigation after a fellowship with the National Health Law Program, working on critical issues related to the opioid epidemic and promoting harm reduction practices, specifically in the communities served by Medicaid and Medi-Cal. Amy will be leading us through the rest of today's webinar. So Amy, over to you.
Thank you, Charles. Welcome, everyone. I'd like to introduce our panelists today. First, we'll have Corey Davis, who's the Deputy Director of the Network's Southeastern Region Office and the Director of the Harm Reduction Legal Project. Corey previously worked as a senior attorney at the National Health Law Program, where he worked on identifying and leveraging legal and policy initiatives to address the opioid epidemic. Before joining NHealth, Corey served as employment rights attorney at Equality Advocates Pennsylvania and oversaw a street-based legal clinic sited at Philadelphia's Syringe Exchange program. In both of these positions, he provided direct legal representation as well as education, outreach, and strategic advocacy. After Corey, we'll have Elizabeth Samuels. Elizabeth is a board-certified emergency physician, health services researcher, Assistant Professor of Emergency Medicine at the Alpert Medical School of Brown University, and the Consulting Assistant Medical Director of the Rhode Island Department of Health Drug Overdose Prevention Program. Dr. Samuels recently launched Rhode Island's Buprenorphine Hotline, a 24/7 Tele-Buprenorphine bridge clinic that helps people start buprenorphine treatment for opioid use disorder and links them to outpatient maintenance treatment. Next, we'll have Zoe Weinstein. Zoe Weinstein is a general internist and a graduate of the Boston University Addiction Medicine Fellowship. Her current clinical work and research are focused on long-term office-based addiction treatment with buprenorphine, the integration of addiction treatment with primary care and inpatient medical care. She is currently the director of Boston Medical Center's Addiction Consult Service. Lastly, we will have Louise Vincent. Louise Vincent is an activist and educator in North Carolina whose work and expertise in drug user health and social and criminal justice reform has driven the expansion and acceptance of harm reduction. She is a harm reduction consultant who specializes in women's health, drug policy reform, and the meaningful engagement of people who use drugs. Louise sits on the board of the International Network of People Who Use Drugs and is on the leadership team of USU, the only national drug user union in the United States. Corey, if you'd like to take the reins.
Great, thank you, Amy. And welcome, everybody. Thanks for joining us today. I'm really excited to have such a great group of panelists. So I am Corey Davis. I'm director of the Harm Reduction Legal Project here. I would say everything that I'm going to say in my part of the presentation is my own views, doesn't necessarily represent those of the network or any of our funders. I would also say, there's the old joke that attorneys are those people who will write a 40-page document and refer to it as a brief. But I am going to try to go relatively quickly through these slides so we can get to Dr. Samuels, Dr. Weinstein, and Ms. Vincent, who have really just spectacular presentations today. So background, as everybody knows, we have got two concurrent public health emergencies going on. There have been over 500,000 overdose-related deaths over the past decade, somewhere around 71,000 last year. It's looking like that number is going to be even higher this year. The United States has been under a declared public health emergency related to what the federal government calls the opioid crisis since late 2017. And of course, we are now in the throes of an epidemic of the novel coronavirus. Somewhere around 141,000 people have been killed in the United States from the coronavirus just this year. And the HHS declared a public health emergency in January, late January of this year, related to that epidemic. And both of those emergencies are continuing. Of course, as with most health-related problems, people who are already at increased risk because of structural inequalities, structural racism, lack of access to preventive care as well as treatment, are being disproportionately impacted by both of those epidemics. So there are a lot of similarities between those two epidemics, but there is one really important difference for our purposes here today, and that is that we don't yet have good medication treatment for COVID-19. There are some medications that there's some evidence may reduce symptoms, may reduce time to recovery among some patients, but there is nothing that works really well. Hopefully that's coming, but there's nothing now. Conversely, we do have very good medication treatments for opioid use disorder, particularly two medications which are called opioid agonist therapies, and I'll let the physicians explain that in a little more detail. But these two medications are called Methadone and Buprenorphine, and these medications work. They are just as good at treating the chronic condition that is opioid use disorder as most other medications we have for managing other chronic conditions. They reduce what we call all-cause mortality by somewhere around 50%. That means your risk of dying from anything, not just overdose. They do reduce overdose risk. They help people reduce what we call risky drug use, things like sharing syringes and so on, reduce chance of relapse. And for people who want to reduce or eliminate their illicit drug use, it helps them do that. Helps them live the lives that they want to lead. And this is, at least on paper, very well accepted, including here's a quote from the HHS Secretary, Alex Azar, saying treating opioid use disorder without opioid agonist therapy is like trying to treat an infection without antibiotics, and that is true. But everywhere you look, there are legal and policy barriers that reduce access to these medications. Now, I assume that most people on this call are relatively familiar with these, so I'm just going to go through them quickly. Starting with buprenorphine. One of the big problems with buprenorphine is that, unlike almost every other medication, you need a special dispensation, if you will, from the federal government to be able to prescribe it. So even if you've gone through medical school, you've gone through residency, you've gone through fellowship, you're able to prescribe oxycodone and fentanyl and every other controlled substance under the sun. You cannot prescribe buprenorphine for opioid use disorder in most cases unless you take additional training. For physicians, that's 8 hours. For other providers who are permitted to prescribe it, it's 24 hours. Might not sound like much, but when you're, a busy working nurse practitioner or physician, it's a real barrier. Once you do have that permission, what we call a waiver, there are limits on the number of patients that you can treat. Again, limits that don't exist for any other medications. There's also this other law that turns out to be quite important in the context of buprenorphine, which is called the Ryan-Haight Act. The long version is the Ryan-Haight Online Pharmacy Act. And what this law does is it says that, in general, before you first prescribe a controlled substance to a patient, you need to have a in-person examination with them, right? You and the patient need to be in the same room at the same time, and you need to physically examine them. And the idea behind this law was to crack down on these sort of online internet pharmacies that were, prescribing where you could log on and tell a physician that you've never met your symptoms, and they would fax over a prescription to, or just send a prescription to an internet pharmacy, and the medications would be delivered to you. And there was a lot of scammy stuff going on around this, and the law was intended to crack down on that. Unfortunately, it also has this really negative repercussion, which is that it means that to initiate buprenorphine treatment, you also need to have that in-person visit with a prescriber, which obviously is a huge problem if you're in a rural area where there are no waivered prescribers, if you don't have reliable transportation to the provider, if you have a disability that makes it difficult for you to access the provider. Just, it serves as a real barrier to people beginning buprenorphine treatment. Methadone is also extremely limited, even more so than buprenorphine. Methadone is the most highly regulated drug in the United States as far as how it can be prescribed and delivered. You can only get your methadone from a federally certified, it's called opioid treatment program. You can't get it from your regular pharmacy. You need to get it from one of these special OTPs, which are colloquially referred to as methadone clinics. Only patients who meet certain criteria can be prescribed medication. So as opposed to every other medication under the sun, where the physician or other prescriber makes the decision, is this medication appropriate for this patient? With the case of methadone, the patient is only permitted to be prescribed the medication if they meet certain criteria set out by Congress, not by their physician. And there are a number of other limitations. The statutes and regulations set out the initial dose that can be prescribed, again, not based on the physician's expert knowledge as an addiction specialist. They are limited by what is in the statute and regulation. And there are a number of other requirements and restrictions, a big one being that, again, the law sets out that most people, everybody initially has to come to the OTP every day to get their medication, where they have to take it under the supervision. Someone needs to watch them take it. Over time, you can, air quote, earn take-home privileges so that you can actually take the medication with you. But there are a number of restrictions on that. And those restrictions limit access to these medications. These numbers are probably a little out of date now, but regardless of what the specific 2020 numbers are, there are not nearly enough waivered providers to meet the demands. There are not nearly enough OTPs to meet the demand. And we know that because we know that most people who have opioid use disorder do not receive medication treatment. Even those who want to access medication treatment often can't do so, particularly can't do so quickly and in a way that respects their dignity as human beings. So enter COVID-19. The federal government, to its credit, has made a number of temporary changes to remove some of these barriers during the COVID-19 crisis. So again, I'm going to start with buprenorphine. So the big one here, the statute, the Ryan-Haight Act, permits the Secretary of the Health and Human Services, in coordination with the Attorney General, to permit during a public health emergency people who aren't otherwise permitted to prescribe those controlled substances via telemedicine to do so, right? So that means that essentially, they can waive that requirement that the provider and the patient be in the same room at the same time to get that initial prescription for buprenorphine. That was originally limited to real-time audiovisual communication, but DEA has used its regulatory discretion to say, actually, a telephone consultation is sufficient. That's really important. Dr. Sanders is going to talk all about it. DEA has also made a couple other changes. They have waived this requirement that each provider be licensed and registered with the DEA in each state in which they practice. That's important because you are considered to be practicing in the state where the patient is, right? So in conjunction with the first change, that permits people to prescribe across state lines. And additionally, the Department of Health and Human Services Office of Civil Rights, which is the main agency that's going to enforce HIPAA violations in this context, has said, look, as long as you're trying to do the right thing as far as practicing telemedicine, we're not going to come after you for potential HIPAA violations in this context. And that's important because not all of the sort of audiovisual communications modalities that people might use follow the letter of the law as far as privacy and security. Okay, so that's all important. Dr. Sanders is going to tell you all about it. Methadone, big changes here. SAMHSA is permitting states to request a blanket exemption to permit all of their, what they call stable patients, to receive 28 days worth of take-home medicines. It means, they can take that medication home with them. They don't need to come to the clinic every morning to be dosed. And 14 days for less stable patients. Now, states need to request that authority, and then each particular OTP can decide for themselves whether or not they're going to do it. But this is actually a huge change in the federal requirements. A couple of other ones here. Big one being that DEA has waived some requirements regarding where the methadone can be provided outside of the physical location that is registered with the DEA. Permits, in some cases, OTP employees to actually deliver the medication to some people's homes so that they don't need to go there in person. Now, these are the highlights. There are a bunch of other things that are going on, but I'm not going to discuss them here. Okay, so this is all great, right? But the problem is that all of those changes are tied to the COVID-19 emergency. So once that COVID-19 emergency order is lifted, they're going to disappear. We're going to go back to the old regime, which makes it more difficult than it should be or needs to be for people to access these medications. And this is bad, right? The opioid crisis was around, we call it the crisis of opioid-related harm, was around well before COVID. It's going to be here long after COVID. So, the idea that these changes would go away once we brought the COVID epidemic under control really doesn't make any sense from the standpoint of public or patient health. So what can we do about this? Well, the easiest way to do this is Congress can just pass a law or a series of laws, both making these temporary changes permanent and addressing these other barriers. For example, none of these temporary changes have addressed the waiver question, right? So Congress could just do away with that. Same with all of the restrictions around, methadone. Congress could simply change the law around that to make it easier for people to access those life-saving medications. But, congressional action can take time. So can we do anything on the regulatory front? Yes, we can. On the buprenorphine side, the big thing is that permission for people to access buprenorphine via telemedicine, just needs to be tied to a public health emergency. It's currently tied to the COVID emergency. it can be tied to the opioid emergency instead. Again, that emergency has been in effect for 3.5 years now. Unfortunately, that emergency situation shows no signs of going away. So as a stopgap measure, it could be tied to the opioid emergency. And DEA can, through regulation, make that permanent. That the statute actually gives them a lot of flexibility to set those requirements around who can prescribe via telemedicine. They can do that via regulation. Didn't have time to get into it here, but there are also a lot of barriers at the state and local level. States often have requirements that are as restrictive or more restrictive than those at the federal level, and they need to change those as well. Now, Congress can do that in the sense that they can tie all kinds of funding to states. It's dependent on them being no more restrictive than federal law or working to actively try to increase access to these medications. And they should do that. Really quickly, one of the concerns here that's always raised, particularly on the buprenorphine side, is what about diversion? And my answer to this, not as a medical professional, but as someone who has read all of the literature, is what about diversion? When we talk about diversion, what we're talking about is people who are trying to use these medications for the purposes that they were intended, to reduce cravings, to help with withdrawal. And in fact, the evidence shows that people who are getting buprenorphine on the black market get the same sorts of benefits as people who are getting buprenorphine prescribed through the regular prescription process. So what that says is that, the problem with diversion is that people need to do it because these laws artificially limit access to the medication. If you get rid of those barriers, you'll see a lot less diversion, because diversion is people trying to treat their opioid use disorder but being unable to do so because of these limits put on in law and policy. Okay, I'm just going to leave you with these conclusions. I apologize, I've gone slightly over. I'm going to turn it over to Dr. Samuels.
Thanks, Corey. So my name is Elizabeth Samuels, and I am an emergency physician who lives and works in Rhode Island. And I'm going to talk to you a little bit about how we've used these relaxed telehealth regulations during COVID to improve access to buprenorphine. Just a quick disclosure, I am supported by an Advanced CTR Mentored Research Award, and our telehealth work has been supported by our Rhode Island Department of Health, Department of Behavioral Health, Developmental Disabilities and Hospitals, as well as the Cobre Center on opioid and overdose. But my opinions, just like Corey's, are my own. A few objectives. So one, I'm going to provide a very brief overview with some background of buprenorphine, just to make sure we all have a similar basic understanding. Discuss a little bit about treatment inequities prior to COVID-19 public health emergency, use of buprenorphine for telehealth, use of telehealth for buprenorphine access, both generally and then during COVID-19, and talk about 2 initiatives that we've developed during COVID-19 here in Rhode Island. So buprenorphine is what we call a partial agonist. So this illustration here on the right side of the slide shows how methadone, buprenorphine, and naltrexone, are 3 FDA-approved medications for opioid use disorder, work on the opioid receptor. So methadone is a full positive press. Buprenorphine is what we call a partial agonist, which means while it has a very high affinity or binds very tightly to that receptor, and it reduces cravings and treats withdrawal, there is a ceiling effect. It's been shown to reduce overdose, reduce death, and as Corey already detailed, it's available through an office-based prescriber or provider, and many opioid treatment programs also provide it, but prescribers must have completed the X waiver course to be able to provide this medication. I won't go over this in great detail, but just a little bit of background data, and you're welcome to look at the references for more information about how medications for opioid use disorder reduce overdose, as well as acute care use. This is a recent paper by Dr. Wakeman and her collaborators, which is in the JAMA Network Open this year. This top line where these red arrows are, it looks at medication for opioid use disorder, both buprenorphine and methadone, in the decreased time to occurrence, decreased overdose amongst folks who take and use medication for opioid use disorder to treat their opioid use disorder compared to behavioral health, naltrexone, no treatment, and detox. And behavioral health, both outpatient and inpatient. And that's the graph on the left for overdose, and on the right, looking at acute care utilization. And we've also reduced death. So this is Sordo et al. The systematic review that Corey referenced as well, looking at methadone and buprenorphine and looking across, comparing use to not use and time of being in treatment, and buprenorphine and methadone, but buprenorphine in particular, really being in treatment reduces all-cause mortality as well as overdose death. Corey alluded to some of the treatment inequities, and there are several main ones that I just would like to review. So first has to do with geography. So because you need to be waivered to prescribe buprenorphine, there are significant inequities in buprenorphine access. If you live in a region or county that does not have a local buprenorphine provider, around 40% of counties don't have a buprenorphine provider, and this primarily impacts rural counties. So this map shows the number of facilities which provide buprenorphine. This is per 100,000 people. So the dark green might seem good, but that's just greater than equal to 10. So that is a pretty low number per 100,000 people, especially if you consider the limits on the number of people each individual buprenorphine prescriber can provide treatment for. There's also treatment inequities by race and insurance. So people who are white and people who have private insurance or who have self-pay are much more likely to get treatment with buprenorphine compared to people who are Black or people who are insured by Medicare or Medicaid. There are numerous barriers to treatment, which Corey mentioned some of them, but cost is a big one, and related to that is insurance. Transportation, particularly in rural areas, if you cannot make it to a physical in-person appointment, you can't access care. Stigma, I think, is one of the largest barriers we have, both to treatment and also a contributing cause to overdose death overall. And then availability of a waivered provider, as I already mentioned, significantly impacts people in rural areas. So buprenorphine for telehealth. So we started to become, people are talking about telehealth for buprenorphine treatment, but it has been something that's been used in the past, but really previously used for maintenance treatment, not for initiation of treatment. And studies that have looked at maintenance treatment for buprenorphine have shown comparable patient retention, medication maintenance, or taking medication consistently, as well as birth outcomes. And if we want to think about equity in buprenorphine telehealth, there's a huge opportunity here. Telehealth could really help decrease inequities related to transportation and geography. However, not all telehealth is the same. An audio telehealth versus a video required component can exacerbate inequities. With video requirement requires smartphones or internet, and there are significant disparities in internet and video access by income, rurality, and age. So this graph is from some research done by Pew, which looks at rural Americans who have access to broadband. So this is a proportion of United States adults that say they have broadband in their home, a smartphone, a tablet, or a desktop computer or laptop. So if we look at the rural areas, home broadband, only 63% in 2019 said they had that, and then we're still below 70%, less than 3/4 of people have a home desktop, laptop, or a computer. During COVID, there were a lot of really founded concerns that the COVID public health emergency was going to result in decreased access to harm reduction services and treatment, and also result in increased death due to both increased use of opioids alone due to isolation, physical distancing, and closure of public spaces, disruptions in the drug supply, which may result in loss of tolerance, which would increase risk of overdose death when people resumed use, increased resumed use after periods of abstinence related to COVID-19 stressors among people who are in recovery, not using medications for opioid use disorder, as well as increased potency of the drug supply related to disruptions in the local drug supply. So in several places around the country, buprenorphine providers responded by providing telehealth buprenorphine in the setting of these changed and new regulations, which Corey reviewed already. So these are two examples of programs. One is from Philadelphia, from the University of Pennsylvania on the left. The other is from NYU. So these folks set up clinics that people could call and get an intake appointment or to continue buprenorphine treatment. In Rhode Island, we did something similar, but a little bit different. Both of those other two programs were connected to existing maintenance clinics. Myself, and along with another emergency physician, a couple of primary care providers, addiction medicine specialists, and a physician's assistant who practices addiction medicine, we started two different Tele-Buprenorphine initiatives. One was what we call the buprenorphine hotline, which is a 24/7 phone number where you can get a consultation to start buprenorphine treatment. It's free for people to call and get a consultation. The medication is not free. You have to go to the pharmacy to get it, but it is free to talk to a clinician. And then we also started an initiative where we were calling people who'd been recently seen in the emergency department for an opioid overdose. We provide harm reduction and recovery resource referral. There were a lot of disruptions to availability and hours of local drop-in centers and regular naloxone distribution programs. So we wanted to ensure people knew what some of those changes were. And then we also offered real-time consultation with a buprenorphine prescriber. So just want to talk about these two programs in a little bit more detail. We had three guiding principles and goals, I would say. So one, our goal was to provide low-threshold buprenorphine access. Really thinking buprenorphine saves lives. It can be a real aid to people. We're worried about folks, as we already talked about, going through withdrawal alone or using it alone and after a period of loss of tolerance and dying. And we really wanted to provide access to this life-saving medication. We utilize principles of harm reduction to deliver patient-centered care, trying to meet people where they're at. And then we wanted to improve equity in addiction treatment access. So the buprenorphine hotline, this is telephone-based. It is 24/7. We provide a consultation and, if appropriate, initiate buprenorphine treatment. We currently are staffed by 6 providers. We're not at the moment billing. And how this is run through our hospital system answering service. During 8 a.m. to 8 p.m., they can establish people with a follow-up appointment before they link them to a provider. And then overnight, we return calls for patients who call the hospital answering service. I realize that some people might not be clinicians on the call, but I just wanted to go over really briefly the general flow of our patient encounter and the protocol that we've developed. So starting the patient encounter, the patient calls the hotline. So at our program, they speak to someone who makes sure they're registered in the hospital system, schedules them with a follow-up appointment, and then once they get to the clinician, we do a consent that they're going to have a telehealth encounter, and then we move on to the assessment. And that assessment is everything that you would have minus the visual component in terms of the interview, everything you would have in a regular healthcare encounter. So you assess for what the severity of opioid use disorder do they have, what's their prior treatment experience, what's their current substance use, have they been on buprenorphine before, what withdrawal symptoms are they currently experiencing, do they have other medical concerns, the next part. For people who have previously been on buprenorphine, I have found it's very helpful because it's much easier to discuss with them, as with anyone you see in a clinic, how to start taking buprenorphine for an unobserved initiation of buprenorphine. You can kind of coach them through the process because the main concern is you don't want to cause precipitated withdrawal in the person that you are trying to treat. So you both provide them information about how and when to start taking the buprenorphine. And the nice thing about the hotline is that if they have questions, they can just call us. Someone is there if they're having an issue or they're not sure if they should take more buprenorphine or they want to check in before they start their dose. We're still there for some ongoing advice if needed. Most patients haven't taken us up on that, which is and haven't reported precipitated withdrawal, which is good. After the patient interview, we go over, determine the dose and duration of the prescription for buprenorphine we're going to write. We usually write for buprenorphine naloxone and Suboxone formulation. Labs that are dependent on which outpatient clinic we have at a follow-up appointment for the patient. And then the patient education materials, you both provide verbal information for patients with an email address. We email them instructions, and then other people, we mail them instructions. And they also get instructions by the pharmacist at the time of the pharmacy encounter. Everyone gets co-prescribed naloxone in addition to the buprenorphine, and then they get follow-up appointment later that week. So we started mid-April, and we have some more follow-up data that we're still filling in. So I only have some limited follow-up data. But we've had about 65 calls to the hotline. We've provided 27 new buprenorphine prescriptions. And we have about 2/3 of folks have made it to their follow-up appointments. We've only looked at about 18 of the patients so far. So 12 of those 18 have had those follow-up appointments. So data evaluation analysis is certainly an ongoing process. And very briefly about the post-overdose callbacks. So I think as many of you may be aware, there's very high risk of death after an ED visit for an opioid overdose, and there's low services provision at the time of an ED visit. This is a paper that was published last year in Annals of Emergency Medicine. There's actually 2 citations that are in the references and on the corner of this slide that both look at risk of death for patients with substance use disorders who are treated in the emergency department. But more than 5% of the people seen in the emergency department for an opioid overdose will be dead within a year. Many of those deaths occur in the first 2 days after their ED visit. So one of the other hotline providers, who's a medical toxicologist and also an emergency physician, she and I worked with a group of research assistants to set up a script and train them to call people that recently had been seen in the emergency department for an overdose. And they provide people they call with information, basically a check-in, how are they doing since their hospitalization, since their emergency department visit, provide information, make sure they know how to find harm reduction resources, naloxone, services programs, peer recovery services, and treatment. And then they offer immediate consultation with either myself or the other provider. So you basically just message me, so this person doesn't want to talk to you, and I then call the patient back within about 20 or 30 minutes. We've probably prescribed buprenorphine for about 10 people. We've called or tried to call a little bit over 250 people. I would say about 40% of those phone numbers are working, and everyone else gets harm reduction, has gotten harm reduction resources. So we're going to be continue doing this through the year, trying to evaluate this type of initiative, both in terms of uptake of services after the ED visit and looking at recurrent overdose and treatment engagement. So the TREATS Act, which I think is currently being reviewed, and I think everyone's really talking about it, looking at it as a lot of promise for maintaining some of the telehealth permissions that we currently have. And there's a lot of great things about this bill. And it does expand telehealth services and provide support to rural areas, but it does require video for initial evaluation. And as I mentioned at the beginning, this would really limit who treatment would be accessible for. Given that one of the main disparities is among people in rural areas and people who are insured by Medicare and Medicaid, both of those groups of people would have lower access to video services, both in terms of availability of broadband internet or cellular service plans with data coverage, and also due to cost. So this is a huge equity issue, and something that I think I'd really love to see this amended to allow for an audio encounter to permit initiation. So just a few take-home points, and then I will hand it over. So one, federal telehealth regulations for buprenorphine during COVID-19 can improve access to treatment, and they could be used to address inequities. There's a need for audio-only capabilities to maintain or ensure or pursue, because we don't have equity yet in access. And there's a need for ongoing evaluation and research to ensure equity in treatment access and measure patient outcomes. Feel free to email me if you have any questions, and use my references. Thank you all so much.
Great, thank you. So again, I'm Zoe Weinstein. I'm going to talk about opportunities and challenges for providing methadone for opioid use disorder during the COVID-19 pandemic. And I didn't come up with my introduction, but I am have been a site physician and/or a medical director for various OTPs, methadone clinics in the Boston area since 2015. Though I'm not formally employed by the OTP, I'm leased out by Boston University, who's my employer. But that is the hat with which I will be speaking to you guys today, to talk about kind of on the ground many of the changes that were outlined by Corey, how those have played out in the real world at opioid treatment programs, and then additional opportunities. I think, we've reviewed a fair amount about what the various treatments are for opioid use disorder. And I think just a reminder that, the goal of methadone maintenance, when most patients enter methadone maintenance, they're continuing to use mostly to avoid feeling withdrawal, to avoid feeling ill. And the goal of methadone maintenance is to stabilize patients so they no longer have withdrawal and are able to be healthy and function and achieve their goals. And we know we need to titrate the methadone to initially kind of lower doses to control withdrawal symptoms, but even higher doses to reduce opioid cravings, and then eventually get what we call opioid blockade, meaning that if somebody did use heroin or fentanyl on top, they would not break through the methadone and not get high, and that would prevent a full-blown relapse. And then the long-term goal is to allow the neural pathways that have been disrupted by chronic opioid use to heal. And so those are the goals, and those are similar to the goals of buprenorphine or other treatments. And I think, as already was highlighted, methadone is a medication that we've had since the 1960s. It has been very clearly shown to prevent overdose and death, as well as infection from HIV and hepatitis C. So it's really a vital, though I think very underused and misunderstood medication. Some of the reason that it is a highly stigmatized medication, even by the patients who take it, is because it is so highly structured. And I know Corey went into a lot of these issues. Like many things, our greatest strength is also our greatest weakness. The kind of opioid treatment program is set up on these ideas of having a daily nursing assessment. The patient physically goes to a dispensing window where a nurse assesses them and then dispenses their dose. In addition to the nursing assessment that happens daily as they get their medications, they have weekly or individual counseling. They have random supervised toxicology screens. There is a medical director, so that's sometimes me who has oversight, though I think some patients feel that is insufficient. There is, as Corey outlined, a standard of observed daily dosing with the ability to later earn take homes, but very strict criteria about how to earn take homes. And I'm going to go over in the pre-COVID era kind of how you earn take homes and what things look like now with COVID. Due to travel, the need to come daily, it can be very inconvenient for patients. I tell patients when they come to my methadone clinic during non-COVID times, you have to come here 365 days a year. New Year's, your birthday, any holiday you celebrate, you still have to come here. And that can be very inconvenient. It usually is highly protocolized care, which patients can find very punitive. For example, many clinics have standards that if you miss 2 days in a row, you automatically get your dose decreased, and other, what can be perceived to be very punitive, like very protocol-based care. It mixes stable and unstable patients. So, lining up at the window to get your dose might be a patient who's in recovery for 3 years, and a patient this is their first day on the clinic and is actively using. And so many patients can find that a triggering environment. So similarly, there's lack of privacy where patients are kind of, again, all in the same line together, waiting for their medications. It's often a very siloed treatment system where there is no other medical care on site. So there are some programs that provide more integrated care. That's not the norm. And similar to the map that Dr. Samuel showed about buprenorphine, the data is even worse with methadone clinics, where there's some states that literally have no methadone clinics at all, and some with very few. And then it's a highly stigmatized treatment, and really no ability to kind of graduate from it besides earning take homes. I just wanted to review what are called the 8-point criteria, and I'll say this is kind of a black box probably to most physicians as well. Actually, I work in our addiction medicine program, and I think a lot of our addiction providers don't even know this. So this is how pre-COVID you earn take homes. You have to meet these 8 criteria, and I'll get into number 6, length of time in treatment, and I'll show that as well. But you have to be abstinent from all substances that are included in testing. So for example, in my clinic, we also test for marijuana on our panel, even though it's legal in our state. It's on our panel, so that does not count as abstinent. And then I will let you guys kind of read down the list, but abstinence, clinic attendance, usually that's interpreted as both good counseling attendance as well as dosing attendance. And then some criteria about the stability of the home environment and social relationships, and making sure the medication can be safely stored. And that often means that homeless patients are excluded from an ability to earn take homes. And then typically we have to document that the benefits outweigh the risks, so that, this patient will be better able to function in their family or at their job if they aren't coming every day. That's usually the easiest one to document, is number 8. And I just so then I'll go into the time and treatment. So I will say that, there's federal regulations about time and treatment, and then states can have their own regulations about time and treatment and number of take homes that can be earned. But as you can see, it's quite restrictive, where you have to be in the program in full compliance with the 8-point criteria for 90 days before you can get your first dose. That means once a week, you don't have to come. That means on Sunday, maybe you don't have to come, but every other day of the week, you still have to come. And then 90 days later, you can additional take home, 90 days later, a third take home. So it can take a year to earn, to come once a week. And then you can see on from there, if you want to come only every other week, it takes 2 years. And if you want to come only once a month, it takes 3 years. So it's extremely daunting. And then oftentimes if patients stop meeting the 8-point criteria for some reason, like they have a random toxicology that's positive for a substance that's not prescribed, then they would basically go back to 0 sometimes. That could be at the discretion of the treatment team. But in any case, very restrictive, as some of you are commenting in the chat. So I just want to highlight what I think was the saving grace during COVID, which is that we've always had an escape valve, a safety valve for these extremely restrictive restrictions, which is what's called the exception request. And I did a little screenshot at the bottom, like it's literally a website. I log into it and me and my staff and nurses can say, we need to deviate from these very strict regulations for whatever reason. And we have to spell it out for the state and for SAMHSA, the federal government. It's been traditionally used for a single patient for an acute medical reason. So for example, a patient needs to travel and they're traveling somewhere, one of those 5 states without a methadone clinic. So we have to give them bottles to travel with. Or they're short-term disabled, they just had a surgery, they need to stay home, they can't travel to the clinic. It can be used on a clinic, overall global clinic basis. So if we have to close the clinic for like a weather emergency, in Massachusetts we have snow days sometimes, you can do a clinic-wide request. So that was the basically foundation for those blanket exceptions that Corey was talking about, is that there was this mechanism in place, thank goodness, that allowed us to make some of these rapid COVID changes. So I think it was a terrifying time to be working in methadone maintenance when COVID was approaching, because this is an extremely crowded space for a contagious virus. I'll show you a little bit later, but we have almost 800 patients that are coming through our clinic, going to 3 or 4 nursing windows over a span of, depending on the day of the week, 5 to 7 hours. So that's hundreds plus people per hour going through the same physical, small, narrow, crowded, stand in a line. Those people do not look 6 feet apart space. Terrifying. So I will say, Corey kind of showed what happened, but I want to tell you what happened before what happened, which is that radio silence. There was no state or federal guidance about how to adapt care when COVID started. There were no clear best practices, as prior emergencies had really been short-term and regional. So we know a little bit about how to adapt methadone during a hurricane, but we really don't know anything about how to adapt methadone to a highly contagious virus that's a global pandemic. We can't send patients to a different clinic. We have, and we can't close down the clinic. And so I do want to really give a shout out to Seattle. They were amazing. There was a few local clinics there, and they worked really well with their state regulators, who I think were also really just strong. And they basically developed best practices. And basically what happened is Seattle clinics said, we need to put in these exception waivers, these blanket exception waivers of what we need to do for our patients here. And they worked with their state, and their state said, okay. And the state got the federal government to say, well, if you say it's okay, we say it's okay. And eventually, basically what the Seattle clinic started that Washington state allowed became the law of the land for all of us. And so I think it's just such an important message that, a small group of people can make a really big, important change and dictate care. So that, I think, I really like to give Seattle a lot of credit, because they were on the vanguard of those changes that Corey outlined. And so, Corey outlined this. Maybe now that you have seen some of these things, it's clear, just clear that. So the blanket exceptions, meaning that it would apply to all patients in your clinic. So I can write an order or ask for an exception that applies to every single patient in the clinic. I don't have to write it for I don't have to write 790 exception requests, which would take me multiple days. So it says all stable patients, and stable patients, that means AKA patients who meet the 8-point criteria. So patients already with take-homes can get up to 28. And then the quote unquote unstable patients, so patients who didn't meet the 8-point criteria, I as medical director director with my team can give them up to 14 if I think they safely can handle it. So basically the legal responsibility, the onus is on me and my team as medical director to say, well, you know, technically these patients don't meet 8-point criteria, but how many do you feel comfortable giving them? Which is a lot of responsibility on a single clinician, but definitely I think worthwhile to push ourselves. So this means a huge rapid increase in number of patients getting take homes. Huge. And I just wanted to also say that this is, again, from Massachusetts, from our state regulators, just some messaging. One, we were always told you're an essential service, you must stay open, you must keep admitting patients, which we did the whole entire time. And that they tried to empower us as much as we could to share resources, use telehealth. Notably, we were unable to do telehealth admissions as compared to buprenorphine. We could not do new starts using telehealth. The federal government said we could not, but they kind of said do as much other things with telehealth as you can, and they tried to relieve other regulatory requirements. So some additional changes is we suspended kind of annual visits, so routine visits. We decreased the number of drug tests that we were doing. We allowed counseling visits and kind of more routine medical visits to be telehealth or remote. However, we still had to be in person for our intakes. And I just want to give you guys a snapshot of how things went at the individual clinic where I'm the medical director. So as you can see, we maintained our census, which was great. Some patients continue to leave, some patients continue to come. This is, I think, really important, thinking about a contagious virus. We went from 665 people coming physically in every day down to 276. That's because patients are coming in staggered to pick up their take-home bottles, but quite a dramatic decrease in terms of decreasing crowding, allowing social distancing. And then I do want to highlight, if you look at the number of people with take-homes, as you can see, the number of 28 and 14-day take-homes at the beginning was extremely small. And that's because actually in Massachusetts, the state law is more conservative than the federal law, and the maximum for the state of Massachusetts is usually 14. And so those two people on 28 were actually on an exception waiver to get the federal limit instead of the state limit. And similarly, the clinic that I work at, the company, is typically restricting patients to only 6 take-homes. And so those patients who are on 14 take-homes had been grandfathered in from another program. So I think you all will see patients typically are on very few take-homes. And then if you look at the column on the right in June, you can see just how many patients have take-homes now, which is really nice. These are just anecdotal notes from the field, like me and my nurses reflecting on things. These are not facts, but there will be studies, there will be data. There's, as you can see, many more patients with take-homes, and a lot of them are doing pretty well with them. There are some stable patients, even patients who had take-homes prior, who are relapsing and struggling without the in-person support, and sometimes because of the struggling having that increased number of take-homes. Many patients continue to use opioids or other substances, but despite continuing to use, they're able to safely manage take-homes, including every other day dosing. So we decided that even our homeless patients didn't necessarily have to come every day, and so we basically have them come every other day. So we give them 1 bottle at a time, our most unstable and homeless patients. We have noticed, again, anecdotally, a little bit of trouble retaining some of our new patients with some of our care being more remote. And then just some potential changes to retain post-COVID, which I see some people have kind of put in the chat already. So I think one, speeding up the timeline for people to earn their first take-home and their subsequent take-homes would be great. Creating a pathway for patients to get even 1 take-home if they don't meet the full 8-point criteria would be also great. And then allowing telehealth for us for initial visits the way we can for buprenorphine. maybe just close all clinics once a week on Sundays so that people kind of artificially get one take home. And then as Corey alluded to, some alternative dosing strategies. There are mobile methadone vans. They haven't been kind of increased in number by the DEA, I think, since 2007. So having more mobile methadone. So he talked a little bit about methadone delivery and kind of making that part of the infrastructure. And then I see in the chat, people have also talked about pharmacy-based methadone or primary care-based methadone as ways to get around some of the travel and other issues. So anyways, I want to thank everybody for your time, and I look forward to your questions.
Hello. Hello, my name is Louise Vincent, and I am the Executive Director of North Carolina Survivors Union, and I'm on the leadership team of Urban Survivors Union. Both are drug user unions operating in, well, one's a national drug user union, and one is a drug user union in North Carolina. We provide syringe service. We're a syringe service program. We provide services for people who are actively using drugs. I'm also an activist. I'm also a drug user. And what I mean when I say drug user is I am a person who has used drugs since I was about 13, on and off. So I struggle with mental illness, and so substance use has been part of my life, my entire life. And so the only relief I've really found, and the only stable period of time I've had in my life, are the times that I have been on methadone. And I think that's really important to say, because methadone was not suggested to me early on, and I have certainly faced quite a bit of stigma and difficulty remaining and staying on methadone with my job. I travel quite a bit, and I have different treatment goals than the clinics have for me. So I think it's important to say that. I so appreciate this webinar. I so appreciate being asked. This is a topic that is so important, and we rarely listen to the drug user voice, especially the active drug user voice, which is the voice we must listen to if we're going to reduce the fatalities that are plaguing us and have decimated my community, my family, and it's so sad. And Corey made a statement when he started talking, and he said, you know, there's one difference. We have medication for opioid use disorder. We don't have medication for COVID. But there's another huge difference. And one, we blame people for substance use disorder, and in this case, opioid use disorder, and we don't blame people for COVID. And so you can see a striking difference in the way we react. The world essentially stopped for COVID, and we took notice, and and even though we're making many failures right now, but we did see the world stop, and we did see people trying to do everything they could to ensure that people didn't die. And that is not what I have seen as we have faced an overdose crisis that is responsible for the death of more than 149,000 people in the last couple of years. So we know that fatal drug overdose hit a record high last year. COVID-19 is certainly making this problem worse. There's no doubt. You know, my work in my syringe service program, we are having people reporting reversals, you know, 4 times as many as prior to COVID. The drug supply continues to be poisoned, contaminated, now adulterated in ways that it just was not prior to COVID, making MAT so much more important. We have a gold standard for treating opioid use disorder, which is methadone, and only about 7% of the people that use my SSP are on methadone, or buprenorphine or any, or any MAT. And that is mostly because of stigma. When I talk to folks about would they like to be on medication-assisted treatment, very many, and I'm in North Carolina, so I need to say that we have a different environment, much more conservative. We just had syringe service programs legalized in 2016. And so the climate around methadone is still one that it's switching one drug for another. Just to give you a bit of insight, I guess it was about maybe 10 years ago, I was still being dishonest with my own family about being on methadone. Even though my life was going well and everyone was proud of me, it was embarrassing and not seen as something, or not seen as recovery, or certainly a second class of recovery. And that is really hard on folks. So I just want to put that out there. I'm going to try to change the slide and practice this. Let's see if I can do it. It's previous. Let's see. Next page. Okay. So Urban Survivors Union, right when COVID was exploding and people were trying to figure out what to do at methadone clinics, we were seeing from our folks, and people were reporting to us, and I was seeing in my own life, that while we were asking people to stay at home, we were still coming to the clinic. We were still being asked to come to the clinic every day. And one of the things people don't understand about being asked to come to the clinic every day, it's not every day, all day long. It's every day from 6 to 7:30 in the morning on Saturday and Sunday. So when we're talking about, we have 500 people at the clinic, and I don't know how many people come on Saturday and Sunday, but packing all those people, you have lines every week because it's a lot of people to serve during a very, very short amount of time. So one of the first things I was disturbed about is there was no social distancing. No one was wearing masks. The only people that were protected, it seemed, was staff and they were barely protected, but they were at least behind plexiglass. There was a shared water container that you were required to use, that everyone picks up and everyone pours the water into their cup. And I asked a number of times, could I please bring my own drink in? I don't want to use this. People are not, this is unsanitary. It looks, this can't be what we need to be doing. I didn't like it prior to COVID. I really don't like it now. And it was a resounding no. You must use this. And the answer about why we must use it has to do with diversion. So the fear of diversion trumping once again the health of people who use drugs or people that are patients at methadone clinics. So the kind of diversion we're talking about is spitting the rest of your dose back in the drink and carrying it out of the clinic. So that's the level of diversion we're talking about. And I just want to put out there, if that's what you're diverting, you're probably diverting that for someone, a partner, or someone who very much needs the medication, and they're not getting high with it. They're unwell. So I really believe there's a couple different kinds of diversion, and some of it is seeking treatment or seeking assistance. So Urban Survivors Union has been working around trying to change methadone restrictions for years with no attention. Nobody wants, nobody would really talk about it much with us. We couldn't get much play. But finally, it seemed like there was some movement around this. We were, having news media call. We were seeing that people were interested in trying to figure out what to do during COVID-19. So this felt like a real opportunity, and it was necessary. A lot of people that use clinics have co-occurring health issues, and it's just essential that we that we protect people, and it affects everyone. So this doesn't just affect people that use drugs. Also, the very message that is sent to people that use drugs that basically says, you don't matter. You don't matter. Everybody else should protect themselves, but you must come in here, and we're not even going to try to make a difference. And I'm not saying this is all clinics. I am saying this is, some of the clinics, which makes it, something we have to pay attention to. And certainly all of the clinics that I have access to here in North Carolina. And so I think some of the southern, more conservative places, and maybe not just southern, some of the more conservative areas, we see, I'm sorry, my dog just hit me. Some of the more conservative places we see much more restrictive and much more difficult situations for folks. So some of the demands in the letter were no discharges unless there's violence towards staff or other clients, right? That just makes sense. People should not be discharged, for using drugs. It just doesn't make sense. And, we come there, we say we have a substance use disorder when we can't stop using drugs. And so discharging people for using drugs, it can't be what we need to be doing. So we basically said, unless there's, violence and this is affecting other people, this just can't be what we do. So no detoxing during COVID-19. So we saw a lot of this, and we still see some of this. And this is basically, you can't pay your dose. And so what they do is they say, well, we're going to let you have your dose, but we're going to start taking you down, 10 milligrams or 5 milligrams every day until you're off the medication, or until you pay it all back. So it feels really punitive. It is not the amount of time that people truly need to detox. I have seen this result in deadly consequence. So all of these things. So discharging people for using drugs, very much I've seen this happen to people, and right after that die of an overdose. And certainly discharging people and putting them on these financial discharge or financial withdrawal, financial withdrawal is deadly for folks. I'm sorry. And so then we have no X waiver, and that is all around buprenorphine. Research, we have research that shows that most physicians already don't want to treat people who use opioids. So then going and making them do more things and just makes this why treatment is so scarce. This just doesn't seem like something that's necessary, and it just creates more barriers to care. So we advocate for pharmacy-based delivery, take-home privileges extended, and telehealth replacing in-person requirements for methadone counseling, and the initial intake. So then we basically talked about doing away with lock boxes. We found out, many of us didn't know and thought very much that these lock boxes were required federally, at a federal level, but and they're not even required in many places at a state level. These were clinic policies that really just put people at, they don't do anything to protect the medicine for the most part. They really just identify you as somebody that's on methadone, or put you at risk for being robbed for your methadone. There's no evidence that shows that this works. There's child-proof containers and all sorts of other things we do with all other medication to keep it safe and to make sure that that children don't get into it. And then basically we advocated for state and federal Medicaid dollars to cover all take-homes. So you can see this letter if you go to the website. We had over 100 signatures, which was really amazing. Some of them being Faces and Voices of Recovery, DPA, the National Alliance of Medication-Assisted Treatment, I mean, we really had so many people, so many organizations sign this letter that it was pretty huge. Here was a drug user union making treatment recommendations that people were actually paying attention to. And we felt like, maybe people were going to listen to people that use drugs, which is something that the evidence pretty well clearly shows that we need to be listening and talking to people who use drugs if we want to slow the overdose or end the overdose crisis. Let me see, let me change slides. So basically, we know that the evidence is in. We know that methadone works, right? And making these changes is really a matter of political will. I want to talk a little bit about my life. I want to talk a little bit about, what things can look like. There's so many opportunities to provide support and services for people who use drugs. Whether we use a clinic or a pharmacy-based system, there's opportunity all around that. Treating hepatitis C, doing really amazing things, really allowing people to create their own treatment goals and moving from some of these systems that are not helpful. But what we have and what we've heard throughout the webinar is a series of barriers that make it so complicated to be on methadone that many people try to be on buprenorphine when that's not as useful for them. If buprenorphine works for you, that's great. But I myself have tried to move to buprenorphine a number of times unsuccessfully. Fentanyl poisoning our drug supply is affecting people's ability to be on buprenorphine. People go into precipitated withdrawal. There's all sorts of problems with all of these different analogs of fentanyl and people trying to be on buprenorphine. You should be on the medication that works for you. But unfortunately, the medication is wonderful, and it's often the policies that make it impossible to be on methadone. So I just want to say that there's 4 clinics in Greensboro, North Carolina, where I live. I am not, so one of the clinics I am not allowed to go back to without some sort of contract because I travel for work. And so this was their statement to me that I was using the methadone system and cheating to try to make my life better while I use drugs. I want to think about what that basically says. That's basically saying you're trying to make positive changes in your life. And so that's not the way we want to be thinking about this. And I don't think that's a way that helps people. As we have and are dealing with COVID, what the clinic I'm currently at now, we do not provide the 14 to 28 day take homes. They closed over the weekends. And are only open the 5 days a week. So everybody gets 2 take homes, but if you can't afford to prepay for those doses, then you go without that dose. So there's no, especially if you have positive urine screens. So there's no allowance of we'll take care of this fee for you until you can pay when you come back. You simply must have the money or you don't dose. And I don't understand how we could be talking to people like that when so many people have lost their jobs, so many people are struggling, and there's more danger in if you are not able to dose on Saturday and Sunday, and then you miss Monday because you don't feel well and the times are tight, right? Like I talked about. So on Monday, maybe the times they're different at different places, but many of them are only open for a few hours. So let's say it's 6 to 9 and you sleep through it. Then on Tuesday, your dose has to go all the way back down to around 20, which isn't going to hold anyone who is who's actively using or who's it's not going to hold anybody who's using fentanyl or using opiates on a regular basis. So this person is at extremely high risk for overdose death in this space. And then we still have to think about how that affects COVID and how that affects people's ability to stay inside and to do the things being asked of them, and then them coming back to the clinic and potentially exposing other people. They are still doing urinalysis up to almost every week for some people, or for people that are failing drug tests. So just they are no longer observed all the time. But these are some of the barriers that really do impact people. One of the speakers was talking about you need to be prepared to be in the clinic 365 days, every day, no matter what day. And this is true, but not only do you need to be prepared to be in the clinic all of these times and all of these days, you also need to be prepared to be there for whatever amount of time they then decide you need to be there. So, it's always a matter of, well, you never know when they're going to need something from you, whether it be a drug test, whether it be they want some paperwork done, and it doesn't matter what kind of schedule you have or what kind of job you have or what you're doing, that has to be done, because there's no dosing before you go do these other things, all of which is punitive and all of which are barriers. One of the things we talked about in our groups had to do with, for the people that they do provide some of the take-homes to, one of the most distressing and frustrating pieces about being on a medication like this and having all of this punitive action around it is when you finally are doing something and you have, and things are going better. So receiving the 2 take-homes a week, just the 2 take-homes a week, changed my life dramatically to the better, right? Having these 2 take-homes eliminated my need to be there on the weekends, which I have a terrible time getting up between 6 and 7 o'clock to be there when I work pretty late, and I am also an amputee, so driving there, putting my leg on, doing all these things are extremely difficult for me, and other people have other challenges, but it's one of my challenges, and so I would miss weekends fairly regularly. So COVID-19 is one of the first times I've had a stable dose in some years, because I'm not getting backed down all the time prior to, I'm not getting knocked down or my dose knocked down all the time for missing a day because the times are so tight, or because I'm unable to do something that I'm supposed to do. This is, all of these things, all of these barriers prevent people from being able to take care of themselves and really not die, right? What I've seen methadone be able to do in the lives of the people that I care about is so absolutely amazing. The medication by itself truly changes lives, and unfortunately, the level of barriers that we put around this drug, and certainly now with COVID and people not feeling safe and not feeling able to take care of themselves, is really a struggle. So right now they only do intake 1 time a week on Wednesdays, which is not, it's between 5 o'clock in the morning and about 7 o'clock in the morning. You have to come to do an intake. So if you oversleep through Wednesday, you have a whole nother week before you can enter the clinic. And I'm just telling you a story about one clinic in one space in one time. And so I know that's not every clinic in every space in every time, but we just we're about to release a white paper where we did a survey of over 500 people that were using clinics around the country. And I'm telling you, these are stories that we hear over and over and over again. And so the the lack of care and the lack of, you know, the lack of, I don't even have words, you know, when we treat people like they don't matter, and when we show them, basically, you know, when you set COVID right next to the overdose crisis, it is so clear to the drug using community that we don't matter. This is a disconnection that really creates an environment where people aren't even trying to take care of themselves. And this is what I see at the syringe service program so many times. People not wearing masks, people not changing their routines at all because of COVID. And many of the reasons why they don't have to do with the way they're treated and their ability to take care of themselves. So when you're, you know, they have sort of, we are pretending to have policies at the clinic that look out for your safety. So they have little lines on the sidewalk that go all the way down. But once you get inside, everybody's packed on top of each other, and still very much doing counseling in person, and so some of these recommendations that have been made, and some of the changes that have been done and done well in other places that I've heard about, are so vitally important and would make such a difference, not just for COVID-19, but would make such a difference for ongoing, you know, for past this pandemic, and really begin to shift what we are seeing as now an increasing rate of overdose again. You know, one of the things that concerns me so much is that we are pouring dollars into the overdose crisis and the opioid epidemic, if you will. But yet we don't even have treatment on demand, low threshold methadone. Many places don't have low threshold buprenorphine. So we aren't even doing the things that we know work. So many times we're hearing about people, you know, not even referring people to MAT because of the costs. You know, the costs around daily dosing of buprenorphine is upward of $30 a day. It is more expensive to daily dose on buprenorphine than it is to buy drugs on the street. And so these can't be our answers. So I hope that just, you know, I think sometimes we hear about clinics and we think about drug treatment, and we assume that it's more compassionate than it actually is. What we are finding is most people have some level of treatment trauma. There is a culture of it's a culture of distrust and blame, and you know, like I said, like I could envision a clinic that could be so powerful for people that use drugs, where people could actually talk to clinicians about, you know, abscesses and issues they were having around other, you know, all health is connected, correct? Right? So I could see drug users being able to share with doctors and folks that understood what they were experiencing. You know, being able to be treated for hepatitis C, having these things in one place. I could see this being a powerful way to improve health of people that use drugs. But that's not what we're doing because of the culture that we continue to have in methadone clinics. What I see is people waking up every day to go to a place that reminds them that they're not important and that they're pieces of shit, and that they did this to themselves. And that may seem like a lot, but you know, it doesn't take many times of going to stand in a methadone clinic line where you can see the apathy and the just like inability to do anything about, you know, all that is happening to you. So, you know, somebody asked me one time, well, why would you continue to go to a place like that when you say it's so negative. I believe for me, the alternative is death, right? I honestly believe that the methadone clinic has, or not methadone clinic, I believe that methadone in my life has made such, it removes me from a criminal environment. I'm not, I don't have to be exposed to all of the things that you have to be exposed to when you are dealing with illicit substance use. So I appreciate you listening to me today. I hope you could listen with an ear that could hear it could remove sort of the stigma from the story that I share. It's really important to me that we keep talking about this, and I appreciate the invite. Thanks.
Thank you, Louise, and thank you all for attending today's webinar. And again, thank you to the panelists for presenting today. Just a few final notes to all of our attendees. If you submitted a question that did not get answered, I will be directing those questions to the speakers shortly after the conclusion of today's event, so make sure that your questions get answered. And all attendees will be receiving an email from the network with the video playback of this webinar, as well as a link to our brief webinar survey. The survey takes just 1 minute to fill out and provides us with some really great insights, especially in regards to what topics you might be interested in for future webinars. And you will also be receiving an email from ASL and me with information on how to apply for CLE credits for this event. So that concludes today's webinar. Thank you all for attending and have a great rest of your day.